Good morning. I'm Suhaken Sharara, the head of infectious diseases, and I'm gonna be talking today on skin and soft tissue infections. I will be addressing the bacterial infections as the viral and the fungal infections will be addressed in a different presentation. How do we classify skin and soft tissue infections? They are divided into primary pyodermas, infectious gangrene, and wound infections. So let's start with primary pyodermas. I designed this lecture into cases to help you memorize the information. This is a first case of a 30-year-old man who works as a janitor presenting with facial skin lesions that have progressed over the past 2 weeks. They are pustular with an erythematous base, and he has no fever or chills. This is how the lesions will appear, and the ones that have yellow liquid in them, we call them pustules. The one with the clear liquid, we call them vesicles. A swab was taken from one of the pustules and yielded gray colonies, which are shown on the slide. And the gram stain revealed gram-positive cocci in clusters, which is highly indicative of Staphylococcus aureus. This condition is called impetigo, where we expect to see clumps of fragile vesicles or pustules that tend to become confluent and produce enlarging skin erosions. This can be due to either Staphylococcus aureus, as in this case, as well as group A Streptococcus or Strep pyogenes can also cause impetigo. This condition is common in children in warm weather, and it can start in the extremities and rapidly spread to other areas. Blood cultures are rarely positive, and this condition is typically treated by topical antibiotics, and we use systemic antibiotics targeted against Staphylococci or Strep pyogenes when the lesions are diffuse. Acute rheumatic fever is not a known complication of impetigo, whereas acute glomerulonephritis can occur following a Strep pyogenes impetigo. This is another example of how an impetigo would look, and as you see, you have some vesicles here with clear fluid, and others look like pustules. Another image of impetigo on the face, which can be very disfiguring, but the kid who has impetigo will not look acutely ill, despite the fact that the lesions are very disfiguring. Let's move to the second case. This is a 70-year-old man, previously healthy, presents with a malar butterfly rash on the face with fever and chills. So as you see here, as opposed to the previous case, the patient has systemic manifestations of infection with fever and chills. He has decrease in his appetite, and he does not recall any injuries to the face. This is what we call a malar rash, as you see here. And this condition where you see a sharp demarcation between the normal skin and the abnormal skin is called erysipelas. Here on the leg, you see another example of erysipelas where you have a sharp demarcation between the normal and the affected skin. In erysipelas, we have warm, shiny red edematous and indurated lesions. It is typically caused by group A beta hemolytic streptococci or Strep pyogenes, but also rarely it can be caused by group G streptococci. The bacterium gains access via an invisible break in the skin, but it can also occur as a complication of a surgical wound or an ulcer that get later complicated by erysipelas. And as we have seen with our gentleman, it's most common on the face as well as on the legs. Sometimes with erysipelas, you have large bullous lesions, as are seen in this lady here. These can rupture and then they get a superimposed infection with another bacterium. It can be another gram-positive or a gram-negative bacterium causing a superimposed infection. Now, once healing occurs, you see that there is hyperpigmentation at the area that has been affected. Whenever we have erysipelas, particularly in elderly patients, immunosuppressed patients, or when we have severe erysipelas of the face, it's much better to admit the patient for intravenous antibiotics because they can be very ill. This is a gram stain of what a group A beta hemolytic strep would look like. As you see, long chains of gram-positive cocci. This is a third case here, and in this condition, look at the difference between this leg and the previous leg that I showed you with erysipelas. This is a 25-year-old girl, presents with redness, pain, and swelling of the right calf area following an insect bite. This is probably here the port of entry. She is ill. She has a temperature of 38.5 degrees. And this condition, we call it cellulitis. Similar to erysipelas, where you have warm, erythematous, edematous, and painful skin, the difference between erysipelas and cellulitis is that you do not have a sharp demarcation in the skin between the normal and the affected skin, as opposed to what I've showed you in the erysipelas. Cellulitis can be due either to group A beta hemolytic strep or to Staph aureus, and it's very difficult to tell the difference between which organism is causing the cellulitis. This is in a normal host. Obviously, in an immunocompromised host, the cellulitis can be due to many other organisms, including gram-negative pathogens. It could be preceded by a wound, followed by local erythema and tenderness that spreads rapidly and can involve the lymphatics as well as the bloodstream. And that's why it's important when you have a febrile patient with cellulitis to take a blood culture, as sometimes you can isolate the organism from blood cultures. I mentioned that you cannot differentiate clinically between strep and staphylococci, and therefore, when we have to treat empirically a patient with cellulitis, you need to give an antibiotic that would cover both bacteria. How do we decide on admission? It really depends on the severity of the illness and the host. If it's an immunocompromised host, it's better to admit. If the infection is severe, if the patient has many findings of a systemic illness, high-grade fever, chills, or a cellulitis extending over a large surface area, it's better to admit the patient for intravenous antibiotics. Let's take another example of a cellulitis. This one is on the face of a child. This is a 5-year-old boy, presents with fever and malaise. On exam, he has hypotension and a purple-red color, as you see here on the right cheek. Whenever we see this presentation, we need to think about Haemophilus influenza cellulitis. Typically, it's an illness that affects children, but it also can affect patients who have chronic bronchitis, chronic respiratory illnesses, but we tend to see it much more commonly in children. The children will present with high-grade fever with septicemia. It's most common on the face, and on exam you have indistinct margins, and the blue-red or purple-red color should give a hint to the nature of the organism. In adult, it can cause cellulitis of the neck and the upper chest, particularly, as I mentioned, in patients who have chronic bronchitis, or in those who have tracheostomy. They can have Haemophilus influenza cellulitis on the neck and chest area as well. Whenever we talk about skin and soft tissue infections, we need to consider the epidemiological exposure. What has the patient been doing prior to presenting with with the cellulitis picture. Let's take this example of how an epidemiological history is important to guide your differential diagnosis. This is a 50-year-old butcher presents with erythema, pain, and swelling of the interdigital area. On exam, the lesion is painful and nodular. He has low-grade fever and malaise. When we see such a presentation on or between the fingers, we need to ask the patient what has he been doing prior to this presentation. And having in mind the type of bacterium that can cause this illness, we need to think about the epidemiological exposure. This is a classical example of erysipeloid cellulitis, which is caused by Erysipelothrax rhiziopathy. This is a gram-positive fraud, and this infection tends to occur in fishermen, butchers, or anybody who is handling raw fish or poultry. It typically occurs on the fingers or hand because this is the part of the body that touches the meat or the chicken. The lesion is purple-red, warm, and can be tender. And therefore you can see this presentation prior to handling meat, or you can see it in fishermen, for example, who go to fish and come back with such lesions. And we need to consider that because you can treat it with penicillin, cephalosporin, or fluoroquinolones. Another epidemiological piece of history that can guide us into deciding on how to manage a patient is if you have someone who has been in contact with animals. This is a 25-year-old man bitten by his cat while playing. He washes the area with soap and water, and 6 hours later he presents feeling pain in his left wrist area. He presents to the emergency room with a temperature of 38.5 degrees Celsius, and on exam he has redness, swelling, and pain of the wrist area, as you see here. Whenever we have a cat bite or any contact with cats that results in cellulitis, we need to consider the organism Pasteurella maltosida. This is a gram-negative organism, unlike the Staphylococci and the Streptococci. It's the most common cause of wound infections associated with cat bites, and it's implicated in up to 30% of dog bite infections. It is characterized by a rapid onset of intense cellulitis. It often develops within hours or a day after the wound. Upon examination of the area that's affected, it's expected to find serosanguinous or seropurulent discharge. And in the microbiology lab, the organism can be confused morphologically with Haemophilus influenzae. And that's why if you have a cat bite and you send a specimen from the wound to the laboratory, you need to tell the lab that you are considering the possibility of Pasteurella maltosida. One thing to keep in mind is that animal bite wounds are often polymicrobial, and therefore when you cover your patient with antibiotics, you not only have to cover for Pasteurella maltosida, but you also have to cover for other organisms that can be present in the mouth of the animal or on the skin of the patient. And therefore, typically, we also add coverage for Streptococci, Staphylococci, and sometimes for anaerobes of the oral cavity of the animal. How do we manage a cat bite? We need to do radiographs because we need to make sure that there are no fractures at the site of the bite and that there is no foreign body that has been retained. Wounds should be cleansed very liberally with saline, and if there is any evidence of devitalized tissue, it needs to be debrided cautiously. One thing to keep in mind is that Pasteurella can progress very rapidly, and it can involve the tendon sheets, not only the skin and subcutaneous tissue, and therefore sometimes If the patient fails to improve on antibiotics, they will require urgent surgical debridement. Let's now move on to another skin and soft tissue infection that can occur typically in severely immunosuppressed patients. This is a 20-year-old man with acute leukemia on chemotherapy who is currently neutropenic. When a patient is neutropenic, they have lost their ability to fight an infectious process. This patient was admitted with fever and chills, and upon physical examination, there was nothing found except what you see here, a small lesion that is red with the central necrosis. The patient is admitted, blood, urine were sent for cultures, in addition to a swab taken from the ulcer that was also sent for culture. Because this is how we manage patients with febrile neutropenia, after the cultures were taken, he automatically was started on empirical antibiotic coverage with cefepime because we wanted to cover for streptococci, staphylococci, as well as gram-negative pathogens. The blood cultures after 12 hours of incubation yielded Pseudomonas aeruginosa. Amikacin was added to cefepime while awaiting the susceptibility result of the organism. Over the next 24 hours, the ulcer got larger, more necrotic with central purulence, as you see here. So very rapid progression of the skin lesion from a small lesion to a largely necrotic area. This condition, we call it ecthyma gangrenosum. And whenever we say ecthyma gangrenosum, Pseudomonas aeruginosa is the first organism to come to mind, although there are now more and more reports suggesting that ecthyma gangrenosum can happen with many other organisms, including gram-positive pathogens and gram-negative pathogens. But the one that is highly to be considered in a febrile neutropenic patient is Pseudomonas aeruginosa. It can start as cellulitis, nodules, or abscesses, and it is associated with a poor outcome if we don't very aggressively treat the patient. And typically, when we see such lesions, we immediately have to start anti-pseudomonal coverage. Let's now move on to the case number 8. And again, this case is another illustration for how the epidemiological history can give us clues to the etiology of the skin condition. This is a 50-year-old woman who went snorkeling in the Red Sea. She sustained an injury bumping against coral reefs, and initially she felt pain in both lower extremities. She took paracetamol and went to sleep. The following morning, she woke up with severe pain in both lower extremities. She became very concerned when she saw very large bloody bullae in her legs. And look at how the skin lesions appear. This is how the lesions have progressed overnight on both lower extremities. Whenever we see such a scenario, we need to consider an organism called Vibrio vulnificus. This tends to occur in patients with underlying lacerations, puncture wounds, bites, or fishing injuries, and it can occur even in immunocompetent patients. Vibrio vulnificus can cause cellulitis, vesicles, bullae, as well as inflammation of the muscles or myositis. It's a very rapidly progressive infection and often can be associated with septicemia. Whenever we think about Vibrio vulnificus in the right clinical and epidemiological scenario, we need to cover the patient empirically in the hospital setting, and typically we give combinations of antibiotics with doxycycline plus third-generation cephalosporin or fluoroquinolones or aminoglycoside, and typically we give a combination of 2 different antibiotics. This one here is a very benign condition, and I bet every single student has had it or had it in one of his family members. This is a 35-year-old man, previously healthy, presenting with a small painful lesion on the face. He is not sick, has no fever and no chills. This is folliculitis, very common condition. It's due to Staph aureus infection of obstructed hair follicles or sebaceous gland. Typically, as in this case, fever is absent, and very often there is spontaneous drainage of the area of folliculitis. Sometimes when the lesion is big, it might require surgical drainage. We advise people not to touch lesions on the face and nose because they can spread rapidly, and if we manipulate them, they can leave a scar on the face. How do we treat folliculitis? This is a very benign condition. We treat it with warm soaks plus minus either topical anti-staphylococcus antibiotic, and sometimes when the lesion is big, we can give oral antibiotics for just a few days. I'm moving to case number 10 to describe a 20-year-old man who goes on vacation to the Bahamas. He spends 5 days there, and upon his return, he noticed the appearance of pruritic skin lesions all over the body, but sparing the face. On exam, he had no fever, and the lesions were superficial papules, pustules, and had a violaceous color. Now again here, very important to recognize that this patient had skin lesions that were sparing the face, and he's coming from the Bahamas. I'm stressing again the importance of the epidemiology to point to the diagnosis here. So what can someone do that can touch the entire body but not the face while he is on vacation? Typically, people spend time in pools, swimming pools, but also it's common that they sit in jacuzzis. And this is what this patient had, and that's why his face was spared, because he was not touching his face in the jacuzzi. This is a Pseudomonas folliculitis. Unlike the severe condition of ecthyma gangrenosum that's due to the same organism, Pseudomonas aeruginosa, Pseudomonas folliculitis is a very benign condition. We also call it hot tub folliculitis, which is not a true cellulitis. It is associated with use of contaminated hot tubs, whirlpools, and swimming pools. And again, when it's sparing the face, it's more likely to be a hot tub and a whirlpool exposure. The rash occurs 2 to 4 days after exposure, and it can cause superficial papules. They can be pruritic, itchy. Typically, the color is more towards violaceous color, and sometimes they can form into red nodules. Characteristic distribution in areas of friction or moisture is often encountered, and typically you don't need to treat Pseudomonas folliculitis. After you avoid exposure to the source, it gets better. But when it's severe and it's bothering the patient, we can treat it with a short course of oral antibiotics. Case number 11, this is a 27-year-old man presenting with pain in his posterior neck associated with fever and malaise. On exam, he had a purulent area on a very erythematous and swollen base. The patient recalled having had a pimple in that area that he tried to squeeze and manipulate 2 days earlier. This is how the lesion looked like, and as you see, a lot of purulence, redness, swelling, and this was exquisitely tender on palpation. This is what we call carbuncles. In Arabic, we call it kharraj. There is a large cutaneous abscess. This is typically due to Staph aureus infection of hair follicles. It can be a susceptible Staph aureus or a methicillin-resistant Staph aureus. The skin is red, warm, and painful, often accompanied by fever, and in some cases it can be complicated by bacteremia. Whenever we have a carbuncle, we need to treat not only with antibiotics with antistaphylococcal drugs, but very often it does require surgical drainage. This is what I covered so far is all under primary pyodermas. And although I don't think it's important for you to memorize the drugs that we use to treat pyodermas, but it's important to think about what are the organisms that are typically causing the condition. And depending on the organism that we are targeting, whether it's Streptococci, Staphylococci, Haemophilus, Erysipelotrix, or others, we need to decide on the choices of antibiotics that will target these particular pathogens. Obviously, if we are thinking of a Pseudomonas aeruginosa and we need to treat the patient with oral antibiotics, the only class of oral antibiotics that will target Pseudomonas aeruginosa is the oral ciprofloxacin or levofloxacin, which are quinolones. I'm moving on now to case number 12. This is a 70-year-old diabetic patient, morbidly obese, who presents to the emergency room with fever, chills, and severe pain in the buttocks area. On exam, the patient is febrile and hypotensive. Whenever we have a patient with skin and soft tissue infection who presents with a low blood pressure, we need to consider the possibility of sepsis, and it really implies that the patient is suffering from a severe infection. On exam, there was redness, swelling with central black discoloration in the left buttock area, and the pain is out of proportion to the physical exam findings. Whenever you hear a description of a pain out of proportion to the physical exam findings, we need to consider a condition called necrotizing fasciitis. So as you see here, some mild erythema, some middle necrosis, but the pain is so severe the patient was screaming. This is necrotizing fasciitis, which in diabetic patients, it's often caused by a combination of aerobic and anaerobic organisms. Antibiotics alone will not cure this infection. What we need is aggressive, immediate surgical incision and debridement together with intravenous antibiotics. Otherwise, the mortality of necrotizing fasciitis is very high. The infection process is deep beyond the skin and the soft tissue. It goes to the fascia, and that is why we really need to have aggressive surgical interventions. When we give antibiotic, we need to consider that these are polymicrobial infections, and we give antibiotics that target Enterobacteriaceae, but also Enterococci, Streptococci, and anaerobic organisms. This is another example of a necrotizing fasciitis on the leg of a patient, and as you see, the skin looks very moist. Multiple black areas of necrosis are seen. There are some conditions that should always make us think of anaerobic soft tissue infections. What are the clinical findings or clues that we look for? The first one is anytime we have a skin and soft tissue infection that is caused by a trauma, a foreign body, or contamination by soil, we need to consider that anaerobic organisms are playing a role. When we have an infection in an ischemic limb, for example, we need to consider that anaerobes tend to play a major role in ischemic limbs because they like areas that are deprived of oxygen. Anaerobic infections should be also considered when you have absence of the classical signs of warmth, erythema, and tenderness. Also, another clue that should make us think of anaerobic infection is if we have soft tissue crepitance or if we have what we call putrid exudate containing gas bubbles. Putrid means foul smell. So if while examining the wound, you see gas bubbles coming out of the wound and you have a very foul smell to the wound, then you need to consider that anaerobes play a role. Any infection with rapid spread along tissue planes should also make us think of anaerobes part of the infectious process. And if you see gas on X-ray, that is also another clue for the presence of anaerobic pathogens. But in general, anytime we have a diabetic foot severe infection with ulcers and purulent material, and particularly when we have a poor blood supply to the extremity, we need to consider that anaerobes play a role in a polymicrobial infection. This is an example of when you see gas on an X-ray, and this is when you need to also consider anaerobic pathogens playing a role in the process. The third and last part of the presentation is to speak about wound infections. Wound infections can be either post-operative or they can occur after accidental trauma. Let's start by surgical wound infections, and as you have heard before, up to 40% of surgical wounds can get infected. It all depends on several things. First, the type of surgery. If the surgery is being done on an organ that is not an organ that has bacterium, for example, the heart, the breast, the hand, the leg, after adequate skin decontamination, the likelihood of infection is much lower than if you are operating on a colonic procedure, because the colon, for example, is full of pathogens. So the type of surgery plays a role. Second, the length of surgery. The longer the duration of surgery, the more likely for it to be associated with an infection. If you have a patient who stayed in the operating room for 12 hours, he is much more likely to have acquired an infection than if he has spent 2 to 3 hours in the operating theater. And the third factor is the susceptibility of the host. The more immunocompromised patient, the more likely they are to develop post-surgical infection. When we have a surgical wound infection, typically the contamination occurs during the surgical procedure and not because of the dressing we put on the skin later on. And it usually is caused by either the patient's endogenous flora or the bacteria that were present on the hands of the personnel who did the surgery or who assisted the surgeon. Surgical wound infections typically present with warm, erythematous, swollen, and tender wounds. There is often purulent discharge, and whenever we have a purulent discharge from the wound, we need to send the specimen for gram stain and culture. Sometimes the patient can present with fever and elevated white blood cell counts. Non-surgical wound infections, typically the contamination happened by the bacteria either present on the skin of the patient or the bacteria that was introduced by the object that penetrated the skin. Whereas Staph aureus infection is the most common, it really depends on where the wound happened and how much contamination there is. So for example, if someone was playing football and injured his leg with an open wound and there was contamination of the wound with the soil, then you can expect polymicrobial infection with Enterobacteriaceae, Clostridium species, and Bacteroides fragilis playing a role in the infection. There are some clues that can help us decide what is the likely organism that is causing the skin and soft tissue infections. So I'm going to give a few examples. I mentioned the putrid smell or the foul smell that suggests anaerobes. Pseudomonas aeruginosa is an organism that typically gives a sweet smell like the grape smell. If by palpation I feel crepitance, that is likely for the infection to be due to either Enterobacteriaceae coliforms or anaerobic pathogens. And if we see on gram stain gram-positive cocci in clusters, then this is likely to be Staph aureus, because there aren't that many organisms that will give us gram-positive cocci in clusters. So there are many clues by physical exam, by epidemiology, by gram stain that can point to the etiology of the offending organism in skin and soft tissue infections. With this slide, I finished my presentation. This is another example of necrotizing fasciitis requiring amputation, but as you see, because the debridement was not done properly, the patient will likely have to go back for another amputation, because as you see, you have here many areas of necrosis. Thank you for your attention and good luck for your examination.